Hello, good afternoon. It's my pleasure to join this meeting with you, although it's online due to the circumstances. But in any case, I would like to thank the organizers and to thank Eden Richter for inviting me to this online meeting and for giving me the opportunity to share with you what we know nowadays about supplementation of the luteal phase after the control variant stimulation in an ART program. Well, we all know that luteal phase support, it is crucial because progesterone is what is going to make an endometrium receptive for an embryo. In a natural cycle, we have the proliferative phase in which the endometrium will develop in response to estrogens, and then the secretory phase in which we transform into a secretory mode due to the action of progesterone. Here we can see a little bit more in detail what it happens when progesterone is started. The endometrium is going to undergo a number of structural changes that will allow an embryo to implant. Well, when we do an embryo transfer, we have three possible scenarios. Embryo transfer can happen in the context of a fresh ART cycle, just a few days after the egg retrieval, or it could happen in the context of a natural cycle or an artificial endometrial preparation cycle in the case of frozen embryos, or in the case also of egg donation. And this is gonna establish the main differences, because the need for exogenous progesterone is going to be entirely different from one scenario to the other. In the natural cycle, we will have one corpus luteum, as in any physiological cycle. On the other hand, in an IVF cycle, we will not have ovarian function, and therefore we will not have any corpus luteum producing progesterone. Therefore, the needs of progesterone are different from one scenario to the other. So let's start with the fresh ART cycle. In the fresh ART cycle, we are going to have a mean levels of progesterone between 25 and 31 nanograms per ml, according to what is published. But as we can see here, progesterone is going to drop below that threshold very soon. It's stated that about half of the production of progesterone that we have in a fresh cycle is coming from the corpus luteum, and the other half is coming from exogenous progesterone, exogenous administration. What do we know about the luteal phase? We know that in all stimulated cycles, luteal phase is going to be abnormal. It's going to be suboptimal due to several reasons. On one hand, because there's going to be aspiration of granulosa cells. Also because in the case of GnRH agonist cycles, we will be under a situation of pituitary suppression because of the long effect of the agonist. Because of the administration of ACG, there's going to be a short loop and a suppression of LH. In GnRH antagonist cycles, we can have also a situation of luteolysis. Also because of the supraphysiological estradiol levels, there's going to be an imbalance between estrogens and progesterone levels. And finally, also there can be direct effects of control variant stimulation on the endometrium. But on the other hand, there are a few things that we don't know. We don't know what is the best choice, what is the best preparation we can give, what is the best route of delivery, what is the timing. It's not clear when progesterone needs to be started and for how long, when should be stopped. And finally, also, there is no consensus on which is the optimal dose of progesterone that should be administered. So let's see what we have available in the literature to try to answer to these questions, or at least to get an approach to them. The choices for treatment are variable. Progesterone, of course, is the most common treatment for luteal phase support, but there are other options, as ACG, as GnRH agonist, as estradiol. So regarding progesterone, we have different routes of administration. We have vaginal progesterone, but we have also injectable progesterone, either subcutaneous, either intramuscular. There is also a choice of rectal progesterone, or even of oral administration. Doses are also very variable according to label. In general, vaginal capsules or pessaries the dose is going to be around 400 to 600 milligrams per day. In the case of the gel, it is 90 milligrams per day, or effervescent progesterone, the doses are of 300 milligrams per day. In the case of subcutaneous progesterone, the single dose is of 25 milligrams per day. In the case of IM progesterone, is 50 milligrams per day. And in the case of oral, in this case, dydrogesterone, the dose is of 30 milligrams per day. So as you can see, it's very, very variable. And also we have different types of progesterone. We have natural progesterone, but as just mentioned, we have nowadays available progestins in the form of the dydrogesterone. Regarding if progesterone has to be given or not, this review shows very clear that when we compare progesterone versus a placebo or not giving any treatment in ART cycles, we can see that with the exception of rectal progesterone, and probably because of a size effect, but it's just a couple of studies, we can see that all forms, intramuscular, oral, subcutaneous, vaginal, all routes of progesterone administration provide a significant increase of pregnancy rates, as you can see, compared to giving a placebo or not. If we compare ECG with a placebo, there are fewer studies, but we come to the same conclusion. We will have a better outcome when we give ECG compared to not giving anything or to give a placebo. But on the other hand, when we compare progesterone versus ECG, we can see that the results are very similar, no significant differences between giving one or other. Probably the issue regarding giving ECG is more related to the risk of OHSS, but in terms of efficacy for pregnancy rates, there are no significant differences when compared to progesterone. And finally, also some authors have suggested that the addition of estrogens to progesterone could increase pregnancy rates as a luteal phase supporter strategy. But so far, the evidence available does not prove this concept, and no significant differences have been observed when estrogens are added to progesterone for luteal phase support. On the other hand, a few studies have compared luteal phase support with progesterone versus progesterone and GnRH agonists, and they suggest that there could be an increase on pregnancy rates if we add an agonist to progesterone in the luteal phase support. Still few studies, but these are what the numbers are telling us. And finally, as the latest arrival, we have recently seen the introduction of oral dydrogesterone as an option, as a choice for luteal phase support. And so far, the studies available show that it works and that there are no significant differences when compared to micronized vaginal progesterone or to a gel. So this becomes another option for luteal phase support, at least in the stimulated cycle, which is where these compounds have been tested and have been compared. When to start progesterone? Well, there is also quite a wide variability in the moment of the cycle in which progesterone is started, ranging from even 2 days before the pickup to up to 6 days after the pickup. And what is the most efficient thing to do? Well, first, if we compare different options before oocyte retrieval, the day of oocyte retrieval, in between oocyte retrieval and embryo transfer, the day of embryo transfer, or after the day of embryo transfer, we can see that the most efficient solution is to start progesterone between oocyte retrieval and embryo transfer. All of them are more effective than not giving progesterone, except starting before oocyte retrieval. But as you see, the starting of progesterone between oocyte retrieval and embryo transfer is the most efficient solution. And going more into detail, we can see here the differences between starting 1 day after oocyte retrieval, 2 days, or 3 days after oocyte pickup, and we can see that the most efficient option is to start progesterone 1 day after oocyte retrieval. So regarding the moment of starting progesterone, that would be the best option. And what about the duration? Well, there's no consensus at all, and practice tends to extend the duration of progesterone treatment during the luteal phase. But if we go to the literature, we will find that even such a different situation that is giving progesterone for 3 weeks, then giving progesterone until the 12th week of pregnancy, there are no differences. So there is no clear understanding on which moment progesterone should be stopped in after a fresh embryo transfer. Some authors suggest that as soon as there is a positive pregnancy test should be stopped. Some others suggest that once the pregnancy is it's proven, it's seen through the ultrasound. Some prefer to wait until there's a heartbeat, week 8, even week 12. So there is not real consensus, and studies have not shown any difference at this point between one or other option. What is the optimal dose of vaginal progesterone in a first cycle? Well, if we look to progesterone plasma concentrations, we can see that the maximum concentration is achieved when we are giving 400 milligrams of pessaries, as you can see here, twice a day. You can see here the green profile is showing the progesterone plasma concentration when we are giving 400 milligrams per pessaries BID, compared to other options that we will provide lower levels of plasma concentration of progesterone in the stimulated cycle. And moreover, it has been shown that the incidence of greater endometrial transformation is achieved with this regimen that I just mentioned, with vaginal pessaries of 400 milligrams given twice a day. We will see that we will observe an adequate response at the endometrium level in terms of transformation, as you can see, in 94% of the patients, which is the highest level compared to the other options that were included in the study. So as we can see, there is a relationship between progesterone plasma levels and the rate of endometrial transformation, and with 400 milligrams per pessaries given twice a day, we will have the highest plasma concentration and the highest incidence of endometrial transformation. The progesterone levels in the stimulated cycles are very variable, but interestingly, according to this study from the group of Peter Humaydan, we can see that when progesterone is high, there is very great variability. When progesterone is about 100, 150 nanomole per ml, we will have a great variability. But on the other hand, when progesterone is low, when progesterone is below 60 nanomole per liter, there is quite a very constant situation. So this means that it would be not that difficult to identify patients with low progesterone, with suboptimal progesterone during the luteal phase in the stimulated cycles, while we will have different levels once progesterone is high. But as we can imagine, the problem situation is if progesterone is low, and it seems that that could be quite easily detectable. Can we predict pregnancy outcome according to the level of progesterone during the mid-luteal phase? Well, this is what was already suggested by a study by Sontag in 2013. As you can see, patients that become pregnant showed higher levels of progesterone in the mid-luteal phase from day 7 onwards, and this is also the situation observed by the group of Humaydan. Now the issue is, can we rescue a cycle if we detect that progesterone levels are low on day 7? If we add progesterone at that point, could we increase the chances of pregnancy of this patient? Well, this is what the group of Humaydan tested, and here you can see on one hand, you can see that, as mentioned, when there is a progesterone level between 60 and 100 nanomole per liter, it is the situation in which the highest live birth rate is observed. This is the early luteal phase progesterone, and when they analyze the mid-luteal phase progesterone, they observe, that this window between 150 and 250 nanomole per liter was the interval in which the highest live birth rates were observed. So according to the data of Thompson and Peter Humaydan, there is an optimal window of progesterone levels in the early and the mid-luteal phase in which lipid rates will be optimized and maximized. Now, the question if can we rescue in case of detecting low progesterone? This interesting study by Ashley in 2017 randomized patients with a progesterone below 15 nanograms per ml on the mid-luteal phase on day 7, which is 10 days after pickup. This is 7 days after transfer. And they randomized them to not to change the dose of progesterone or to increase progesterone by 300 milligrams per day with the first progesterone. And the control group were those patients in which progesterone was fine, was above 15 nanograms per ml. Well, what they observed is that it didn't make any difference. Not to increase progesterone or increase progesterone didn't have any impact in the chances of pregnancy at the end of the day. So it seems that a low progesterone level 7 days after embryo transfer in a fresh cycle, probably a situation it's already lost, and you cannot rescue pregnancy rates by increasing progesterone at that point of the cycle. Well, we are doing more and more cycles in which we are triggering with an agonist, particularly in prevention of OHSS. And well, it's important to keep in mind that when we are using an agonist for triggering, we will have a much more deficient luteal phase because of the short life of the agonist. So you can see here what is the HCG levels in the case of at least search created with an agonist triggering, and you can see how levels are so low. So there is a much shorter luteal phase when we are treating with an agonist, and this obviously leads to the need of a different luteal phase support. And there are a number of strategies that have been already tested and shown to work, as for example, including estradiol and intramuscular progesterone in high doses until week 10. This was the protocol by Engman, the first one, 2008. Different regimens of HCG, multi-low dose, single, double dose of 1500 units. Of course, adding HCG to the trigger, if we trigger with both agonist and HCG, then we will not have this problem. Or even multi-microdoses of 125 units per day. So different options with HCG to rescue the luteal phase in case of an agonist triggering and a fresh transfer. The use of recombinant LH has also been suggested in high and multiple doses of 300 units per day, and even a daily multiple dose of an agonist, the GnRH agonist, have been suggested as an option to rescue the luteal phase in this scenario. Well, what about the natural cycle? And in the natural cycle, progesterone can be also very variable. We can look at the graph here. We see that around the clock, progesterone can oscillate between 6 nanograms per ml to 36 nanograms per ml. So really huge variation, 6-fold variation. But in any way, classically, there has been defined an optimal window of between around 9 and 17 nanograms per ml of progesterone to define an optimal luteal phase with a cutoff level of around 9.4 nanograms per ml. These are really all studies. They are coming, some of them come from the 80s. And classically, a luteal phase deficiency has been defined as a serum progesterone below 10 nanograms per ml, or the addition of 3 random determinations being below 30 nanograms per ml, keeping in mind that the variability is very high. So a luteal phase deficiency diagnosed with 3 random determinations probably is much more reliable than 1 single determination. It's been suggested that in natural cycles, luteal phase support will not be needed, but there are a couple of studies demonstrating that either if we are speaking about a pure natural cycle in which no any medication is given, or in a modified natural cycle in which there is an HCG given for scheduling the transfer, in both the scenarios, an LH supplementation, a progesterone supplementation, a luteal phase supplementation, provide better pregnancy rates. As you can see here, 10 points in favor of luteal phase support in the pure natural cycles, even higher in the modified natural cycle. So even if we are working in a natural cycle, it seems that giving progesterone for luteal phase support is going to increase our chances of pregnancy. Finally, artificial endometrial preparation cycles. Well, this is very wide protocol, because very wide use protocol, because most egg donation treatments, most oocyte recipients will be following this regimen for endometrial preparation, and also with the increase of EGS cycles, in which embryos need to be frozen for analysis, are making the use of artificial endometrial preparation cycle to increase very significantly. Well, in the difference, one of the differences between the natural and the HRT cycle is that progesterone levels are much constant. As I said at the beginning, in the natural cycle, we have corpus luteal production of progesterone, and therefore great variability. But in the artificial cycles, we don't have endogenous progesterone. Therefore, all the progesterone that we're determining is coming from what we are administering. And what we can see here is that levels are quite stable. After a few hours after starting progesterone administration, then if progesterone is holded, levels are going to be quite constant. So in ART cycles, we are just mimicking the natural cycles. We're giving estrogens to make the endometrium grow for the proliferative phase, and then we will add progesterone for the transformation of the endometrium to become receptive and to be able to maintain a pregnancy, and also to induce local immunotolerance for allowing implantation. So it has a number of roles, progesterone, to sustain pregnancy. However, in the artificial cycle, there is no evidence or insufficient evidence to recommend any particular protocol. Again, the optimal exposure and length of progesterone is not well established, and also the mode of progesterone administration is still performed based on a patient and doctor's preference, with important differences across centers. Well, despite this heterogeneity, in general, there is no routine monitorization of progesterone levels in an artificial cycle. In most centers, the protocol is the same for every patient. There is no individualization, and no decisions are taken regarding progesterone levels. So to see if this could be an option, we designed the first prospective study in oocyte donation cycles to see if serum progesterone the day of transfer could have an impact on pregnancy rates. Well, the first thing that was interesting to observe was that progesterone levels are very variable across patients, and they were following all the same. They were following 400 milligrams of micronized progesterone twice a day, all of them same dose of progesterone. As you can see, progesterone levels measured the day of a transfer ranged from 5th percentile of 5.5 nanograms per ml to a 95th percentile of 22 nanograms per ml. So really very different levels of progesterone. So what we did was to compare the outcome according to the quartiles, to the 25th, the 50th, and the 75th percentiles, and then see around these quartiles how pregnancy rates were behaving. And interestingly, we observed that in the group of patients in which progesterone was below the 25th percentile, which was 9.2 nanograms per ml in this study, pregnancy rates were significantly lower compared to the rest of patients. So you can see here, if we group in one side all patients with progesterone levels below 9.2 nanograms per ml, the 25th percentile, compared to the rest of the patients, we see that the difference in terms of ongoing pregnancy rate, and these were egg donation cycles with good quality embryos transferred, 210 patients including the study, we can see a 20-point difference in terms of ongoing pregnancy rate, which was very significant. And very important, because this meant that without notice, we were undertreating about 1/4 of our patients. 25% of our patients were underperforming because of low serum progesterone levels the day of embryo transfer. So from there on, once we start to measure progesterone, interestingly, we can see that the patients with low progesterone had lower pregnancy rates, lower clinical pregnancy rates, and higher biochemical and miscarriage rates. So means that low progesterone impaired both implantation and, in the case of implantation, impaired early embryo development. So this is really showing the importance of having good levels of progesterone, serum progesterone, at the moment of embryo transfer. Now, these obviously raise a number of questions. This, as I said, this was an egg donation population. So first thing we want to see is if this was happening in any other patients in the general population. We wanted to see if this finding was consistent from one cycle to other and if it could be predictable. And moreover, we wanted to see if we could correct the situation. So at the end of the day, we wanted to see how we can solve the problem of these 25% of patients that because of low progesterone were having poorer outcomes. So for that, we have designed a large prospective cohort study in which we include almost 1,200 HRT cycles of patients undergoing treatment either with own eggs or with donor eggs. No restrictive inclusion criteria, because we wanted to see if the finding that we had in egg donation was happening in general population. So we presented the results last year in ESRE and recently have been accepted for publication in Human Reproduction. So you will be able to see the results very soon, but here I'm introducing them to you. Well, what we observed was almost the same that we observed in the first cycle. The percentiles that we found were very, very similar to the first cycle, and we observed that there was a critical cutoff level of 8.8 nanograms per ml, below which the ongoing pregnancy rates were significantly lower compared to the rest of the population. As you can see here, on the first 3 groups, we did 10 equal groups of, I insist, this is more than 1,000 patients, 1,200 patients. We can see how the ongoing pregnancy rates of women with progesterone below 8.8 was significantly lower. And moreover, when we split between oocyte donation and own eggs, and still in own eggs, we split it between no PGTA or PGTA, we observed exactly the same impact of having low progesterone, with differences that were ranging between 15 and 20% in terms of ongoing pregnancy rate. So from this study, we concluded that every patient undergoing an HRT cycle for endometrial preparation has a significantly lower chances of ongoing pregnancy in the case that progesterone it is below a certain level, which is in our hands 8.8 nanograms per ml, which was the 30th percentile of the distribution. So 30% of the patients will have low serum progesterone levels that will impair her chances of pregnancy. Well, in another sample, we analyzed 129 cycles in which we were measuring progesterone after embryo transfer on day +4, +7, and day +11. And it was very interesting to see that patients that had an ongoing pregnancy had progesterone levels that were increasing. And remember that here, there is no ovarian function, so this is not endogenous production. So patients that had higher levels of serum progesterone in the mid-luteal phase until the day of pregnancy test were higher compared to those patients that had a pregnancy but pregnancy loss, and those patients with a negative result. So this was telling us that the progesterone levels from the day of transfer onwards could be more important than the progesterone levels before embryo transfer and the chances of achieve a pregnancy. Moreover, we proved that there is a high consistency intercycle. We proved that 80% of the patients in which progesterone is low in one cycle will have it in the following cycle, and if it's okay on one cycle, it will be okay in the next cycle. And well, this was done when we had a cutoff level of 9.2 before our largest study, but anyhow, it allows us to establish this high intercycle consistency. And also that progesterone levels, as you can see, in most of patients are quite stable from the first day that you're starting progesterone, not the second day. So the goal here was to identify which were the patients that were going to have a low progesterone levels the day of embryo transfer and see if we could do something for them to rescue the chance of pregnancy without needing to cancel the cycle. So what we did was in these patients to add subcutaneous progesterone. Here you can see the results of our first study, 20% difference in pregnancy rate. So what we have done was to these patients with a progesterone below 9.2 nanograms a day of ml, we were adding subcutaneous progesterone in the middle of the 2 vaginal doses. So these patients are receiving 400 milligrams in the morning vaginally, 400 milligrams in the evening vaginally, and we are adding 1 dose of subcu progesterone in the middle of in between the 2 doses. And very interestingly, we have seen that in these patients, we have achieved exactly the same ongoing pregnancy rates compared to those patients in which progesterone was okay the day of embryo transfer. So in other words, this is showing us that in artificial endometrial preparation cycle, we can rescue the cycle by the addition of subcu progesterone. So to conclude, dear colleagues, my summary of the talk would be that yes, appropriate exposure to progesterone during the luteal phase is essential for successful embryo implantation and pregnancy consolidation, regardless of the luteal phase scenario, natural, fresh, artificial. In fresh IVF cycles, luteal phase implantation is mandatory for the reasons we observed. And as we have seen, most regimens have similar outcomes, although it looks that IM administration could have better results. Starting treatment the day after oocyte pickup looks the best choice, and to hold it for at least 3 weeks, although there is no consensus of the moment of stopping progesterone administration. As mentioned before, also 400 milligrams of vaginal progesterone twice a day provides the best exposure to progesterone when we are using the vaginal route, as it provides the highest serum levels and the highest endometrial transformation levels. Also in the natural cycle, progesterone supplementation is going to increase lipid rates as we observed. And finally, in artificial endometrial preparation cycles, a minimal threshold of progesterone levels is required for optimizing the outcome, and therefore monitoring and individualization of the luteal phase support is crucial in these patients. So thank you very much for your attention, and I will be happy to answer your questions in the following minutes. Thank you very much.